So good morning, everyone. I am really excited today to be here in a role as division chief, presenting one of the physicians in general internal medicine, who is Dr. Kathryn Miller. So, just for a little blast back to the past, I don't have a meteorological little note, but I do have Morning Glory Pool, which is a geological note. This is a beautiful hot springs in Yellowstone. So today, I am presenting Dr. Kathryn Miller. She is an assistant professor of medicine, CHS track, in the Division of General Internal Medicine. And Dr. Kathryn Miller's grand rounds is titled, fantastic title, its motion is Lotion, Fundamentals in Caring for Patients with Osteoarthritis. And I'm going to tell you a little bit about Dr. Miller, who has just been a fantastic academic physician in our division in general internal medicine. Dr. Miller did her medical degree, her residency and chief residency here at University of Wisconsin. She then went on and did a fellowship in primary care sports medicine at UCLA LA Medical Center. And she came back to join us right after that fellowship in 2013. She practices at 20 South Park Street. And Dr. Miller holds several leadership positions, one of which is intimately important to the grand rounds today. So she is a clinical service chief for general internal medicine, which is the leadership role really right below the leadership role as a division chief. She also is the site lead for 20 South Park Street. And importantly, she is the medical director for the UW Health non-operative knee and hip osteoarthritis program. And, if you listened to Grand Rounds last week, you heard about doing something that is your joy in medicine. And this niche area in osteoarthritis is really Katie's joy. And her work has developed into an international reputation. And this program is totally based on her vision and her innovation. She's received several honors. She's received the chair commendation for I'm just taking a look, just a note from Dr. Schnapp, just a second. Okay, good. Chair commendation for the Golden Bucky Award for leadership during COVID. She also received the Extraordinary Performance in Time of Crisis Medal Award from the Division of General Internal Medicine. She has been AOA since her time in medical school. And what you might not know about Dr. Miller is that she is a rower and that she was U.S. first team All-American when she was a rower. She has received 2 pilot grants for her work in non-operative osteoarthritis from general internal medicine. She has 5 peer-reviewed papers, 14 posters, and next month has been invited to present internationally on her work. So Dr. Miller, I'm going to go ahead and hand off to you.
All right, thank you, Betsy. And I will skip ahead to my starting slide. All right, so in my wildest dreams, I never a decade ago would have thought that I would become a clinical expert in osteoarthritis. And I really, it's not, the fundamentals for caring with patients for osteoarthritis is, no one thinks that OA is fun. So I hope that I can inspire you today to make a little bit of joy or fun in your practice for caring for this population. Because osteoarthritis is not a condition that is easy to treat. But I hope I can leave you today with an understanding of the paradigm shift that has really occurred in OA management over the past decade, including really useful language that I think you can use with patients to facilitate treatment. So I have no relevant disclosures. And first, I just want to introduce you to a patient. This is JR. When I first met JR, he was really angry. He had been told that he needed a joint replacement. His knees were extremely painful. He could barely walk 20 feet. And yet he couldn't have that joint replacement because his BMI was too high. And he didn't know what to do. He felt trapped. And over time, with the help of the team at the OA clinic, we were able to coach him. His weight improved, his pain decreased. He was able to walk farther and easier. And his pain ultimately didn't improve enough to not warrant undergoing a joint replacement, but he did get his BMI down low enough and was successfully able to get that procedure. And that is what is so fun about this work, is really helping patients get what they need. So by the end of the hour today, I want you to be able to identify the causes of OA symptoms, list the 3 best treatments for OA, help explain to patients how to monitor and interpret their joint pain so that they can better manage their symptoms, and outline components of an exercise prescription for OA. And how we're going to accomplish this is, first, we're going to talk about why OA is even a serious disease to begin with, what the barriers are for us to managing OA, what the clinical capabilities for managing OA are, and then finally, I'm going to tell you about implementation of OA management programs, of which we have done here at UW Health, and how we use quality improvement and implementation science tools to improve care. 32.5 million. This is the number of American adults living with osteoarthritis. It's about 1 in 6 adults in this country. Besides being extremely prevalent, OA impacts mortality and decreases quality of life. Globally, OA is the 3rd most rising cause of disability behind diabetes and dementia. This slide shows the clinical course of OA, and it occurs over time, and it's a really slow process. You know, we don't go from normal joint health to end-stage OA overnight. In this yellow box, there's this long preclinical stage where there's cellular changes happening. And it's really highly suspected now that lifestyle during this preclinical stage, including our activity levels, our body weight, tobacco use, influence the severity and rate of progression. So it's really important to be counseling patients in their 20s and 30s about leading a healthy lifestyle. The other fact to highlight on this slide is the red box, and this is end-stage OA. And it's really important to be clear on the definition of end-stage OA. And so the definition is radiographic evidence of arthritis plus high levels of symptoms without improvement after 6 months of high quality conservative care. And when patients meet this definition, there is clear benefit for them undergoing a total joint replacement. All right, so now we're going to move on. So now we know it's a serious disease. We're going to move on to management and why that's difficult. So OA is difficult to treat. It really is not as simple as telling a patient to take some acetaminophen and avoid things that hurt. You know, there is evidence-based treatment, and we're going to talk about those guidelines today. However, less than 50% of people locally, nationally, and internationally are receiving this treatment. So I want you to take 30 seconds and find a piece of paper, jot down an answer to either why is managing OA difficult in your medical practice, or if you don't directly manage it, how does OA interfere in your management of other disease? And I'm going to pause for 30 seconds and let you think about that, write something down. All right. Well, several years ago, we wanted to know what those barriers were here at UW Health. So we did a qualitative survey of many of our primary care physicians, and we asked them, what is challenging about managing OA in your practice? And maybe some of the barriers that we heard in that study are similar to what you wrote down. But what we heard from physicians here at UW Health were, 1, they didn't think that there were any effective treatments. 2, they thought that patients don't want to or simply can't make needed lifestyle changes. They said that lifestyle counseling takes time, and quite frankly, we don't have time in our busy clinical day. And they also felt that patients couldn't be convinced of the utility of lifestyle treatment, that patients were looking for things like injections and surgeries to fix their OA. We also, as part of this study, asked their patients what made it difficult for their physicians to treat their OA. So again, we're asking patients about why it was difficult for their physicians to treat OA. And the patient said that their physicians didn't have enough time during appointments. They said that the physicians didn't have good patient education tools, that the physicians didn't have shared decision-making tools, that the physicians actually didn't provide a clear diagnosis or clear treatment recommendations. In fact, several patients that we interviewed were confused as to why they were even invited to participate in our study, because they didn't think they had osteoarthritis. They thought they had bone on bone, whatever that is. And they also said that their physicians were unable to take into account their individual preferences. So hopefully, as we go through and talk now about the clinical capabilities of managing OA, we will help you be able to overcome some of those barriers. So because it's so challenging to treat this condition, and because so many people around the globe are struggling with this, a group of experts came up with this clinical capabilities for OA management. And we don't have time to go through all of these today, but I'm going to highlight the 5 that I think will make the biggest impact on your clinical practice. And I will also provide key messages that you can use with patients, as well as language that's recommended to be avoided. So the first area we're going to talk about is investigations and diagnosis. So the key clinical capabilities that I want you to know in here are this. This table has got the diagnostic criteria for osteoarthritis of the knee. Here's the European criteria in the first column and the American College of Rheumatology criteria in the second column. And what you notice is that it's really based on symptoms and clinical signs. So OA is a clinical diagnosis based on symptoms, and it's not based on structural changes seen on imaging. Despite imaging not being needed or even recommended for the diagnosis, of course, patients are going to ask for it, and many of us will routinely order it when a patient presents for chronic or acute joint pain. And I'm not necessarily discouraging you from doing this, but I think it's important for us to understand the limitations of imaging and to educate patients on these limitations. And this brings us to our next key message. The imaging results are poorly related to pain. And what I mean by this is look at these x-rays on the right-hand side of your screen. The top x-ray is what I would consider to be moderate radiographic osteoarthritis. And the bottom x-ray is what I would consider to be severe radiographic osteoarthritis of the knee. And yet I can tell you clinically that the patient of the top who had moderate OA, radiographic OA, had very severe symptoms. And the patient on the bottom really had no joint pain at all in the right knee, and really only mild joint pain and limitations on the left knee. And so again, imaging does not predict progression or degree of symptoms. And this is really the biggest paradigm shift, is that OA is no longer thought, the pain and symptoms in OA are no longer thought to be related to structural damage on x-ray. Only slightly they are, and to a much bigger degree, all of the other types of pain. And we're going to talk about that a little bit later. So a key message to tell patients is that joint damage on an x-ray does not indicate how your OA will affect you. And also, because of this, we need to avoid harmful language. When we tell patients they have bone on bone, that they have wear and tear disease or that grinding, they assume that their symptoms are due to anatomic changes and that they need injections and surgery then to fix it. And multiple studies have shown that using these languages is harmful to patients. All right, the next area of key clinical capabilities that we're going to talk about is self-management and behavior change. We need to teach patients about pain and how pain is abnormal. And we need to teach them about what the key strategies are for managing OA. So the key message here is that education, exercise, and weight control are the best OA treatments to start with for all patients. And the message here that you should give to patients is that non-drug treatments have similar benefits for OA symptoms as pain-relieving drugs, but without the side effects. They're going to do great. And then the other area to focus on in this is really, let's dive a little bit deeper into what OA pain is. Again, OA has historically been understood to imply that symptoms are due to structural damage. And again, this leads to the view that non-surgical approaches are futile and that we must fix the damage with surgery. But really, contemporary evidence supports OA as a whole person condition. in which knee health is influenced by the interaction of different biopsychosocial factors. And the three types of pain that are really prevalent in osteoarthritis is nociceptive pain, that's caused by ongoing inflammation and damage of the tissues, neuropathic pain caused by nerve damage, and nociplastic pain, which is really augmented CNS pain and sensory processing. And just to kind of diagram that all out for you, pain locally is influenced by people's behavior, their disability, psychosocial comorbidities feed down to local pain. Things like their physical activity level, their muscle strength activity, structural pathology, all, there's up and down here through the signaling pathways. And again, just to highlight that in a different way, there are many contributors to pain in osteoarthritis. Biologic, sure, of course, but also behavior, sociological, and psychological. And so really the key messages here to give to patients is that pain does not mean that you have damaged or that you are damaging your joint. Pain is influenced by many factors. And more importantly, the message that we should be giving to patients is pain is a normal part of exercise. So when patients come to clinic and they say, oh, someone told me that if it hurts, I shouldn't be doing it. When we tell people that message, we're actually harming them, because the less active people get, the higher their pain levels tend to drift over time. And so we really want to teach patients that pain is normal and expected, and we want to teach them how to manage their pain better. And I work with a great physical therapist in the OA clinic, actually many great physical therapists in the OA clinic, but one of them, Jessica Johnson, really has this great story that she talks to patients about. And I think it's a great thing to highlight to patients is, if I'm at home at night watching a romantic comedy and someone comes to my door, I'm just going to go and answer my door, no big deal. But if I'm home late at night watching a horror film and someone comes to my door, I am going to be really skittish. I'm going to look out the window. I might grab my phone to take with me just in case. And that's really the essence of pain in OA. It really is contextual. So then how can we help patients manage their pain? And what we use for this is something we call the 24-hour recovery rule. And this is just a common PT rule. There aren't actually great references because it's so old. I did put in a few citations of how, as examples of how this is used. But really it's a tool that patients can use to monitor and interpret pain over time. And basically what it means is that if they completely recover from an activity within 24 hours, they're fine. That pain that they might have had with activity is not harmful. But if they have ongoing pain for more than 24 hours after the activity ends, then we get a little bit worried. So just to give you an example, let's say a patient starts at a 3 out of 8 pain, or 3 out of 10 pain. That's their baseline level of pain. And they do an activity, whether that's going to the grocery store, walking around the block, exercising, whatever it is, and their pain might go up to a 7 out of 10. I'm not actually that concerned about that increase of pain up to the 7 out of 10. As long as that increase in pain comes back down to a 3 out of 10 level, remember I said they started at 3 out of 10. So if their pain comes back down to that 3 out of 10 level within 24 hours, I am completely reassured, and they should and can continue doing that activity. Versus a person who starts at a 3 out of 10, goes up to a 7, and still is, at a 5 out of 10 pain, has not returned to normal within 24 hours, then I become a little bit concerned that that activity wasn't great for them. And so just to diagram this for you, this green line, let's say it's patient number 3. Their pain is always at a 2 out of 10 level. No matter what day of the week it is, no matter what they do, I'm not concerned about that pain as being harmful. Now we're going to add in another patient, patient 1 in the blue line. This patient, their pain goes from a 2 to a 5, but it goes back down to a 2, goes up to a 5, and goes back down to a 2. I am not worried about this patient either. When their pain goes up to a 5, that is normal, expected part of osteoarthritis, and they are just fine. They can continue to do those activities and be reassured. We're going to add in patient 3. This patient, they start the week at a 2 out of 10. And as the week goes on, their pain just increases. So whatever they're doing throughout the week, we're going to have to modify, because this pain pattern is a signal of harm. And so certainly we wanted to dive deeper into it and really help them modify their activity so they're not continually to harm their joint. All right, moving on to the next area of key clinical capabilities, we're going to talk about rehabilitation interventions. And as we start this, we're going to talk a little bit about what we in the OA program call Motion is Lotion. And we're going to talk a little bit about joint physiology. So again, these slides were drawn for me by Jessica Johnson, the physical therapist. So here's a drawing of your knee. We're going to cut out this little box and blow it up on the next slide. These blue cells are chondrocytes. Chondrocytes are the living cells in cartilage, and they are mechanico-sensitive. This means that joint physiology is dependent on physical stimulation, like exercise. Our joints need exercise to work. So chondrocytes don't make up very much of the cartilage, but they have really big jobs. They build the extracellular matrix to maintain cartilage, fluid, and structure, and they stimulate this large glycoprotein called lubricin. So when we exercise, we are making this glycoprotein called lubricin. And what lubricin does is it has 2 big jobs. It lubricates the joint, and it is actually a very strong natural anti-inflammatory. So really, exercise is a great way to maintain joint health. And we need to exercise in order to get these natural joint properties. So the key message to give to patients then is that exercise is helpful to all people with osteoarthritis, and it is good for our joints. We have to reassure patients that our joints are strong and they're designed to take a load. And then we also need strong muscles to keep our joints healthy. A couple other things to remind patients in this area is that actually there's really no evidence that we get more osteoarthritis by being physically active. We do get osteoarthritis by injuries that occur from being physically active, but in general, physical activity is thought to be safe and does not increase our risk of getting osteoarthritis. And if patients want to increase their physical activity and get more physically active and fit, they're going to need to gradually load their knee or other joints to build capacity. All right, and if you have superstar athletes out there who really have knee osteoarthritis and have given up running and really want to return to it, my message to those patients is, getting back to running is possible for some people, but certainly not all. And it requires weight management and graduated strengthening and loading. So let's plan to coach you back to your goals. And this is where a physical therapist can be really helpful. So another thing to consider in this area is a clinical exam pearl that I like to use even in my primary care clinic for these patients with knee or hip osteoarthritis. And it's something we call the 30-second chair rise test. And I like it because it's quick, it's easy, you don't need any space or special equipment. You're going to have the patient sit in the chair in your exam room. If they can, fold their arms over their chest, and you're going to time them for 30 seconds, standing up and sitting down as many times as they can. If they can't do it with their arms folded over their chest, fine, let them use their hands, or even just say, let's see how long it takes you to do 3 reps. And we're going to have a little fun here. So I'm going to stop and I'm going to say ready, set, go. And I want you all to try this for 30 seconds and see how many reps you get. And then I'm going to share with you the average scores based on sex and gender. All right, on your marks, get set, go. All right, and stop. And I will tell you that Dr. Jeremy Smith passed this with flying colors, and I'm sure you all did too. And here are again, the average scores based on sex and age. And again, a below average score indicates a risk for fall. And the fun thing about this is patients are going to improve really quickly, and they love to come back and show you how many more reps they can get. All right, so if you're in clinical practice and you want to, okay, I'm going to refer the patient to physical therapy, but I want to give them some idea of how to get started because they may not get into PT for a while. So the initial exercise prescription that you might consider for osteoarthritis of the lower extremities is, stationary biking. Certainly they could do a seated stepper, a treadmill, an elliptical, whatever they can do using that 24-hour rule. If people are completely inactive, we want them to start really slowly, 5 to 10 minutes a day. Some patients, we even start at like 2 to 3 minutes a day or less. You're going to have them slowly increase to 30 minutes, 5 days a week or more. And remember, the principle of this is motion is lotion. We're stimulating our chondrocytes to help our joints be their best. Second is strength. We want people to be able to get stronger. And so sit to stand, they can do that chair rise exercise, do 2 sets of 12 or whatever is appropriate based on their initial score. Or if they can't do that, another great exercise is the weight shift to shallow squat. And the nice thing about this is there's not as much shearing force through the joint when patients do this. So this is a picture of the weight shift to shallow squat. So this gentleman, you want someone to kind of lean on something that's a little bit taller than a chair. And then really they're just going to rock their body forward. So their weight is, off of their glute area, and just hold it for 2 or 3 seconds and then sit back. So again, it's another way to strengthen quads, really without changing the position of the knees to decrease that shearing force. And then last, work on strength and balance with this single leg balance. Really just have them stand on one leg as long as they can, working up to 3 times 30 seconds per leg. All right. Now we're going to talk about pharmacotherapy as the next area of key clinical capabilities. And to do this, I'm going to use the 2019 Osteoarthritis Research Society International Guidelines for treatment of OA. And these guidelines, in this red box here, really recommend everything we've just talked about, right? Evaluating people's pain, all of the things that might be impacting their pain, and then selecting those core treatments, weight management, exercise, and education about pain. And if patients still do not have acceptable state, then you move on to pharmacologic therapy. And that's over here in this box. And we're going to go through these guidelines pretty detailed for knee and then hip osteoarthritis. So for knee osteoarthritis, you can see that the guidelines are arranged by level of evidence. The treatments are broken up into pharmacologic and non-pharmacologic at each level. And then also based on patient comorbidities. So if they don't have any comorbidities, if they have GI, cardiovascular, if they're just otherwise a frail person, or if they have widespread pain and depression. And so for knee osteoarthritis, the best level of evidence, there's only pharmacologic, and it is topical Nsaid. So this would be topical diclofenac gel. And for knee osteoarthritis, it's 4 grams of gel, which is about 4 inches of gel, 3 to 4 times a day. If that doesn't work, then you could move down to, and you can really use it for most patients. You might want not to consider it for patients with cardiovascular comorbid conditions, or for people with widespread pain or depression. Rubbing this on their knee probably isn't going to help their symptoms that much. If that doesn't work, you move down to level 1B. And here there's both pharmacologic and non-pharmacologic treatments. And here is really where the oral anti-inflammatories come in, including the COX-2 inhibitors for some populations. And for people with comorbid conditions, considering intra-articular corticosteroid injections and intra-articular hyaluronic acid injections. Here's also where aquatic exercise comes in, gait aids such as walking sticks, canes and walkers, self-management programs, and cognitive behavior therapy. If those things still aren't enough, then you're going to move down to level 2 evidence. And this really is where intra-articular hyaluronic acid injections would pop up for all patients. You might consider adding in other anti-inflammatories for people with GI conditions. And here is where duloxetine and local treatments come in for people with widespread pain and depression. And then, of course, they say always good clinical practice. There's not the strongest of evidence but really always considering intra-articular treatments, Nsaid risk mitigation, and pain management programs. So just to highlight a few things that I really want you to remember from that table is that intra-articular corticosteroid injections for knee osteoarthritis are recommended for acute pain, really 1 to 2 weeks, or short-term pain, lasting maybe 4 to 6 weeks at the most. So really when people's baseline level of pain is at a 3, and for whatever reason that baseline level of pain has popped up to a higher level and we just can't get it under control, that's a really good time to recommend an intra-articular corticosteroid injection for knee OA. For people who have, and then intra-articular hyaluronic acid injections, they are conditionally recommended for longer-term treatment effect. They've been associated with a functional improvement of treatment at 26 weeks, and they have a really good safety profile. And then Nsaid risk mitigation, right? So we always want to use the lowest dose for the shortest period of time. Now, I do get patients in clinic, and you probably do too, who are so afraid of even taking a single tablet of ibuprofen, right? They've heard so many bad things about it. And what I would tell these patients is really, I want you to use anti-inflammatories as a tool. I'd rather have you take that single dose of ibuprofen, if it's in the appropriate patient, and move than not take it and sit on the couch, because there are a lot of risk of leading a sedentary lifestyle. And I also tell patients, I'm hopeful as we get you moving more, your symptoms are going to improve and you're not going to need that ibuprofen. So really, it's a short-term strategy. Now we're going to talk about the hip osteoarthritis guidelines. And I will say there are a couple of things about this. One, there has been much less research and evidence done on hip OA than knee OA. And so as you can see, there's no level 1A evidence for pharmacologic management of hip osteoarthritis. Level 2, really, there's no topical treatments. So it's really going into the oral anti-inflammatories, mind-body exercises, those gait aids, self-management programs. Level 2 doesn't really add much to level 1B, and then good clinical practice, weight management, Nsaid risk mitigation, pain management programs. And I think that really the key things to highlight for hip osteoarthritis is that weight loss, weight management hasn't been shown to be as effective as it has for other types of osteoarthritis, such as knee and ankle. Partly because there's been less research done, but partly because it just really simply seems that weight loss isn't going to impact patients quite as much. And the other thing I would say is the intra-articular corticosteroid injections for hip osteoarthritis didn't even make that top table. Most experts are recommending against them because of the limited benefit in terms of pain relief for hip osteoarthritis and the increased risk of avascular necrosis that occurs in the hip after these types of injections. So again, for most patients, intra-articular corticosteroid injections into the hip are not recommended. And then of course, Nsaid risk mitigation. And then a couple of things to highlight what's out. So between 2014 and 2019, what was changed? Acetaminophen was really dumped from the guidelines. Most experts really feel that the evidence shows that this is not helpful. Opioid therapy was removed. Bracing and topical capsaicin were also removed. There just isn't the evidence to support using these routinely in clinical practice. And duloxetine used to be a much higher level of recommendation, and now it's really limited to people with depression, widespread pain who haven't gotten benefits from other therapies first. And then the ORSI 2019 guidelines also explicitly recommend against intra-articular stem cell injections and intra-articular platelet-rich plasma. These just do not seem to work at this time. All right, moving on to our last area of key clinical capabilities. We're going to talk about joint replacement. Joint replacement is really beneficial for people with end-stage osteoarthritis. Around that 6 months of effective treatment with not a lot of improvement in their symptoms, and patients should be referred to consider for total joint replacement. And the messages you could give to patients in this area are your OA symptoms can often be eased significantly without requiring an operation. If you cannot achieve pain relief from your OA, if you've been taken, that treatment period and you still haven't gotten better, then joint replacement surgery is the option. And that arthroscopic surgery really is not an effective treatment to treat pain related when there's underlying osteoarthritis, unless there's a mechanical blocking of the joint. And then just to wrap up this section, this is a handout that I love to give to patients, and patients really buy into it, because now it's not just me telling them these things, but it's really, coming from an international group of experts. And so just to highlight these things, in the red box, the myth is that the degree of osteoarthritis on a scan predicts your pain and disability, when the fact is, in the red box, that scans are poorly related to pain and disability. The myth in the green is rest is helpful, and the fact is rest and avoidance makes pain worse. The myth in blue is exercise is dangerous, when really the fact is graded exercise is safe and helpful. The myth is that pain is damage, when really pain is normal and expected part of osteoarthritis. And then I call on you as my fellow clinicians to really avoid things that are low value care and stick with these high value care treatments that we've been discussing today. All right, now we get to go on to the fun part. You are all now clinical experts in osteoarthritis, and we're going to talk about what we've done here at UW Health to improve the care of our patients. All right, so I call this the intersection of quality improvement and implementation science, because I just use tools from both to help me along the way. So back when I started in 2014, I knew there was evidence-based practices. I knew there was international benchmark data suggesting that less than 40% of patients received evidence-based care for OA. And I knew there were good treatment guidelines. What I didn't know is what the variability was in care here at UW and what the outcomes were. And I also didn't know if I was the only one who was frustrated and providing poor care. So we took a look. We did a retrospective chart review. We looked at patients who were diagnosed with knee or hip osteoarthritis in 2011, and we followed them for the next 6 years in their chart. They had to have been a primary care patient here at UW Health for that whole 6-year period, so we made sure that we had all of their health records. And so we ended up looking at 40 charts, and we really didn't see any new treatment patterns beyond the 30th chart, so we kind of felt comfortable stopping at 40. Half of the patients were female. The average age is what you would expect for a new diagnosis of OA, around 56. And BMI kind of split, but in general, heavier population, way more knee patients than hip patients, which is just sort of the demographics of OA. Knee OA is way more common than hip OA. So these 40 patients, they presented to a physician in 2011 for joint pain. Of the 40, 31 were seen in primary care. So they went to their primary care provider for this initial diagnosis and concern of joint pain. 9 of those patients actually referred themselves to see an orthopedic surgeon or primary care sports medicine physician for this pain. So we wanted to know at that appointment, why was it scheduled and what else was covered? So not unexpected in primary care, about half of the time patients came in with their joint pain, they were actually coming in for diabetes or hypertension or whatever else. And this was kind of a, oh, by the way, also my knee is hurting. Could we address that as well? And of course, that doesn't happen when a patient goes to see a subspecialist. And then we also wanted to know at that initial diagnosis, or at the time of the initial diagnosis, what treatments were offered or recommended. And as you can see, most patients did receive some sort of treatment recommendation at that first visit, with 5 receiving OA disease education, a total of 17 being referred to physical therapy, another 4 having some sort of conversation about exercise or activity. Only 3 out of the 18 patients who had an elevated BMI were discussed weight management, and 8 patients were recommended orthotics. No one was recommended to use an assist device. So then we wanted to know what happened over the next 6 years. So that slide again was that initial diagnosis, but then what happened over the next 6 years. So here on the left side, table 3 is really the number of patients referred to subspecialty care over that 6-year time period. So again, these 9 patients, they just started in subspecialty care. They just called up and made their own appointment. 18 patients were referred on to subspecialty care by their primary care provider within that first year of diagnosis. Another 6 patients were referred on after between 1 and 6 years, and only 7 patients remained with their PCP for management of their osteoarthritis for that entire time period. And over the 5 years, 13 were provided disease education, 27 were referred to physical therapy, although not all of them went. 14 were given some sort of exercise or activity advice by their physician or advanced practice provider. 10 out of the 28 were given some sort of weight management advice or referred to a dietitian, and 9 were given recommendations on orthotics over that whole 6-year treatment period. So knowing this and knowing that this is kind of what's happening internationally, and we're not doing better and we're not doing worse, we really wanted to come up with a new way of treating OA here at UW Health. And that's where we stumbled upon this idea of osteoarthritis management programs. And just to give you what the definition is, it's a model incorporating evidence-based non-surgical OA care in a real-world setting, tailored to the individual patient with reassessment and progression over time, using at least 2 of those non-surgical interventions that we have talked about, and adding on other things as needed. So we opened our OA management program here in on July 1, 2017. Patients are referred to us from a variety of different sources. The goal is that we meet with patients for 1 to 5 appointments over the course of a year. And we teach them all about OA, we set goals with them, we manage their medications, we address mood disorders and other things that they might need to be optimized for total joint replacement if that's the route they're heading. Prior to the pandemic, we were offering optional shared medical visits for patients who felt that that would be beneficial to meet with other peers over a more intensive period. We work closely with other subspecialty clinics to help patients get the support they need. And our goal is to graduate patients within 12 months, saying, you know everything you know about OA, need to know about OA, go ahead and do it. So our initial data, between July 1st, 2017 and January 15th of 2021, so about a year ago, we had seen 953 patients in this clinic. Average or mean age was 62. Most were female, most were white. Most had Medicare as their insurance. Primary care was our biggest referral source, followed by orthopedics. The patients are not very healthy. So the mean body mass index for a patient starting in our clinic is 40.97. Their Charleston comorbidity index, the mean is 2. Most of them have knee osteoarthritis. Again, that's just way more common than hip osteoarthritis in general. And their pain is kind of, you know, some people have moderate pain, some people have mild pain, some people have severe pain when they start. It's kind of evenly divided. Functional tests, they do worse than we would like them to do. That should be 30-second chair rise test. The average number of reps was 10, and the timed up and go test, the average initial starting score was 13. The VR12 is sort of an overall health score. So there's a physical component and a mental health component. The average American adult has a score of 50. So if you have higher than 50, you're better than the average American adult. And if you're lower than 50, you're rating your physical or mental health as below the average. And so, you know, physically, these patients are not doing great. All right, so then we wanted to look at some implementation outcomes. Like we said, patients should come 1 to 5 times over the course of a year. We thought that would be an effective treatment dose for them, but what were patients actually doing? So for about 40% of patients only come once. Another 36 come for 2 to 3 visits. 18% come for 4 to 6 visits, and a few hang on for much longer. And so, you know, again, most people then are fitting in with our initial model, although I am surprised at the number who only come once. And what about the duration of treatment? So each of these yellow bars is 100 days. And so about 49% of patients, you know, their treatment ends within the first 100 days. Another 22% treatment ends within 200 days, and so on. So again, most people are completing treatment within that first year as we had wanted. And then just looking at treatment duration by different factors, wanting to know if there might be some things that really had people not stick with treatment as longer. So you can see in this first one, females and men, really no difference in their treatment duration. By insurance, people who self-pay certainly end earlier or do not stay with treatment as long as people who have different types of insurance. Days of treatment by initial pain severity level. Really, you can see here the green line. It's a little bit hard to see, but that's the one that's ending earliest. So people with the most severe pain do not stay as long. And I suspect that's because we're sending them back for total joint replacement sooner. And then looking at Charleston Comorbidity Index, really people who have the most severe and highest Charleston Comorbidity Index do not stay in treatment as long. They probably have other more important things to address. We also looked at, why among our first 50 patients, we went back and looked like, why did those first 50 patients stop their care? 13, we don't know. We asked them to come back. They didn't schedule an appointment. We never heard from them again. 12 graduated, they met their goal, they got their OA roadmap for future care, and they went on with their lives. 9 were not engaged. We had seen them for over a year. They weren't making progress. They came back every time. We tried to send them to other places. 4 or 5 we sent on for total joint replacement. 4 we ended up referring to the pain clinic. 4 stopped for finances or logistical reasons, and 3 had other health complications that made it not possible to continue in this treatment. So then we wanted to know sort of the patient outcomes, right? Did patients improve? So you can see over here on the right-hand side, let's take a look at that graph first. So people who started with mild pain, about 30% of them had improvement in their pain over their treatment period. People who had moderate pain or had about 53% of them improved over the treatment period. And people who rated their pain as severe initially, almost 68% of them improved over their treatment period in terms of pain. And you can see compared to people who had mild pain, on the left-hand side, you can look at the odds ratios. People who had moderate pain had a 2.7 odds ratio of improving compared to people who had mild pain, and people with severe pain, odds ratio was 5.1 that they improved in pain compared to people with mild pain. So what about BMI? One of our really big goals, although we're not necessarily a weight management clinic, and we often refer people onto our weight management program, is weight loss. We know that people need to lose weight either to get their total joint replacement and because it really just helps their joint symptoms. And you can see that people who have hot BMIs greater than 30 really definitely improved their BMI over their treatment period, with over 60% of people with a BMI over 30 improving their BMI over the treatment period. And odds ratio, for people with a BMI between 40 and 49 was 4.1 compared to people with normal body weight. So pretty good changes in these populations, and I'm really proud of our team for being able to do that. The next thing that we've looked at is, what do patients think? There's this validated OA quality indicator score, and it basically is a questionnaire that we mailed to patients that said, did you get this, right? And we think that patients got all of these things, and we wanted to know what patients thought. And our mean QI pass rate for all of these quality indicators was 75.6%. And, I have that in yellow because I wanted to hit 80%. But the truth is that internationally, in studies, people are hitting around 30 to 50% on this. So 75% is actually really good. And you can see there's some areas in red that we have some room for improvement on in our OA management program. And these are really interesting because all patients that returned to this survey actually got these things. They were all seen by a registered dietitian to help with weight reduction. They all received a functional assessment. They all, were evaluating them for total joint replacement at every visit, and yet patients aren't understanding what we're doing. And so it really just stresses the need to be really explicit in communication. And I think this is something we can all learn from. We also interviewed patients who participated in our osteoarthritis management program. We interviewed 17 patients. And we're still working through this analysis, but the initial themes is that patients increase knowledge and confidence in managing their OA. The patient cited that the rapport and acceptance by providers and the management program was really important to their improvement. 59% of patients believed that OA could be managed without surgery. However, only about 30% of them knew someone who had managed OA without surgery, and I'm hoping that that increases over time in our community. They cited the barriers to adhering to the care plan as COVID, our clinic location, and prior treatment recommendations. When patients had heard that they needed injections or surgery prior to coming to our clinic, they had a harder time buying into these non-surgical treatments. And they felt like the handouts, the patient education, and the team approach was really helpful to their care. And so just one quote, she laid out all these options for me, here's some things we can try. We should probably see if you can get some relief from these treatments. And it was worth it. They were minimally invasive. They were essentially pain-free. And yet I was able to gain some range of motion and some stamina from doing them. So in summary, symptoms related to OA are not simply due to structural damage, but instead influenced by many biopsychosocial factors. The 3 best OA treatments to start with include education, exercise, and weight control. Pain is a normal and expected part of OA. Teach your patients the 24-hour recovery rule. And then the principles of exercise with OA is motion is lotion, balance, and strength. OA-MPs are one strategy to improve treatment for patients with OA. And we have one here at UW Health. We'd be happy to see your patients and help you out. And finally, just thanks to all the people that have helped me along the way. It's been a really fun journey. And I will stop sharing my slides and happy to answer any questions.
Great. Thank you, Katie, for a wonderful grand rounds. I apologize for some technical difficulties early on.
No worries.
I also think that every grand rounds moving forward, we should do the sit stand in the middle of it for 30 seconds. We should do our own little controlled study and see how everybody's sit stand numbers improve.
Right.
And I'm really glad you talked about running and knees, because people tell me all the time, oh my God, you're running, you're going to destroy your knees. Or I used to be able to run, but I can't run anymore because of my knees. So I'm going to refer them all to you. And really impressive multidisciplinary program. I think it really is a model for how we care for patients. And I think the challenge for you, I would ask, is how are you going to educate all providers, ideally to provide similar support for patients, given the prevalence of OA in our populations?
Yeah, I think that's a huge challenge. And I mean, I'm hoping that's one thing that we're starting today by doing this grand rounds. But I think there's a lot of work to be done, because it's very clear when patients hear those things before they come to us, particularly from a physician they've trusted over many years. And then we tell them something like, well, injections actually don't work that great, or yeah, you're just going to get moving. They look at us like we have a third head. So it's really important as a healthcare community, we're all on the same page and giving these same messages.
And one thing, what is your tipping point for sending them for evaluation for joint replacement?
Yeah. So, often like the patient like JR, he came in, he had severe radiographic osteoarthritis, and he had been told he needed a joint replacement. So really those patients, they have in their mind that that's what they need. And we really focus on, okay, how do we improve your quality of life temporarily? How do we get your weight down so you can achieve that? And we also tell patients that about 30% of the time, and we see this, that when patients have been given that message, they need a joint replacement, and they actually do the things they need to do, their joint symptoms improve so much that they come back and they say, why did anyone ever tell me I needed a joint replacement? I have no knee pain at all. So we plant that little carrot too, that we're going to do all this in the hopes of getting you to a joint replacement, and we are going to celebrate if you don't need one, and we're going to celebrate if you get your joint replaced. Either way, you rock, right? So really just planting that message.
Great. A quick question, procedure to numb or freeze the nerve supplying the knee, is that helpful, useful, not
Yeah.
useful?
So I think what they're referring to is that geniculate nerve block and the radiofrequency ablation of that geniculate nerve. And I would say, it's not in the guidelines, but we actually do use it fairly frequently at the OA clinic and are seeing really good results. Michelle Poliak-Tunick and I published with a Shapiro student a couple summers ago a paper on that. And regardless of BMI, actually patients had pretty good outcomes in terms of pain reductions over 6 to 12 months with that. So it is a really good tool to use for some people.
Okay. Question from Adam Gepner at the VA. Have you considered a virtual or group-based treatment? And plug for the new VA GeroFit program, which incorporates community engagement.
Yeah, I mean, Adam, I think we should talk about that because I think there is some room for collaboration here. Our shared medical visits, were in person pre-pandemic, and those were actually had really great outcomes in terms of weight loss and getting people to move because, after the first visit, at least one patient would try what we were recommending and they would come back and then they would tell the group that it actually worked, right? So then patients buy into it more. So yeah, I mean, I think there's lots of opportunities here.
Yeah, I will say my own personal experience, my mother never believed anything I told her that she needed to do. It was, if her friends or her manicurist told her.
Exactly.
Many comments just thanking you for the amazing presentation. It really was great and loved hearing about, the evolution of the multidisciplinary program and being able to evaluate the impact of it is really critical. So I applaud you for that work. And the entire team.
Thank you.
Okay. Any weight loss pearls for all of us?
I don't know. What we tell people in the OA clinic is really there's no one right way, right? It has to work with your lifestyle and it has to be sustainable. So, people come in wanting to try keto or fasting or whatever, and we'll support them in whatever they want to try because they have to buy into it. But really, we know what works best is a whole foods, plant-based diet. I mean, that really helps pain and it really helps manage weight.
Yeah. And I know we're working towards a non-surgical weight management sort of multidisciplinary program as well. Question about how do can you distribute the pamphlets, the education materials for other clinics?
Yeah, actually, that's a great idea. I'd be happy to, maybe we can work with HealthLink or something to get them approved and as tools and handouts right in the EHR.
Yeah, that makes a lot of sense. And yeah, I think there's a lot of comments. People feel more equipped to deal with it, more tools in their toolbox. So thank you. And with that, we are just about out of time. Again, great talk, strong work. And congratulations on getting that multidisciplinary clinic up and running and moving forward. Really kudos.
All right. Thank you. Have a great Friday.
Okay, thanks. Bye-bye.